Hey everyone, welcome. I'm absolutely thrilled to have you joining us for today's Clinical Explainer. Let's treat this like our virtual grand rounds, okay? I'll be acting as your attending physician today, and man, do we have a high-stakes, real-world respiratory case to tackle. We're going to break down a really complex clinical presentation using a structured, step-by-step approach that you can take straight to the wards. Our focus today is on two very alarming symptoms showing up together: coughing up blood and losing weight. It's a scenario that demands immediate action, sharp clinical reasoning, and above all, a cool head.
Okay, let's dive into this. Here is our rounding schedule for today's case. We'll start with the initial presentation, move right into the diagnostic algorithm, have a face-off between tuberculosis and carcinoma, discuss managing an airway emergency, and finally, reach our conclusion.
Section 1. The presentation, a high-stakes symptom. Let's set the scene here.
So you're on call, and a patient is admitted. Before we even think about ordering a single test, I want you to put your investigator hat on. Your patient is coughing up blood and losing weight. What is your immediate next move? In clinical medicine, your very first instinct shouldn't be to panic, but to categorize and define exactly what it is we're dealing with.
First things first, we've got to define the symptom. This is hemoptysis. Simply put, it's the expectoration of blood, or blood-streaked sputum, specifically coming from the lower respiratory tract, meaning it originates below the level of the vocal cords. We absolutely have to differentiate this from hematemesis, which is throwing up blood from the GI tract, or, just a really bad nosebleed. And keep in mind, hemoptysis can be anything from a few tiny streaks of blood in the sputum to a massive, literally life-threatening hemorrhage.
And guys, when I say life-threatening, I mean it. The mortality rate of massive hemoptysis, it sits somewhere between 30% and 80% if we don't manage it aggressively. But here is the absolute most critical piece of physiology you need to take away from today. Patients with massive hemoptysis don't typically die from exsanguination. They aren't bleeding out. No, they die from asphyxiation. To put that into perspective, the anatomical dead space in the human airway is only about 150 milliliters. That's practically nothing. It takes a terrifyingly small amount of blood to completely fill that space, block gas exchange, and essentially drown the patient.
Let's move on to Section 2, the diagnostic algorithm, a 3D moving approach.
Because the stakes are just so high, we cannot afford to guess. We rely on a structured, three-dimensional clinical algorithm to guide us from these vague, terrifying symptoms to a concrete, actionable diagnosis. Let's move to the algorithm and see how this builds. It's basically a flowchart with three distinct phases. Step 1 is gathering the history and symptoms. Step 2 is the targeted physical exam. And Step 3 relies on precise bedside and lab investigations.
Starting right in with Step 1, we need to act like detectives and extract specific clues from the patient's history. Like, what exactly are their pack years of smoking? If you've got someone over 40 with a heavy smoking history and new-onset hemoptysis, they are at a super high risk for malignancy. Are they having fevers and drenching night sweats? Well, that points us toward a chronic infection. We also need to quantify the weight loss, like has it been more than 10% of their total body weight? And absolutely crucial, we have to ask about their travel history to areas endemic for diseases like tuberculosis.
All right, Step 2 takes us straight to the bedside for a targeted respiratory exam. We're hunting for physical evidence pointing to specific diseases. Do they have clubbing of the digits? That can signal lung cancer or bronchiectasis, but, and this is a key distinction, it's rarely found in simple TB. We'll also palpate for lymphadenopathy. A swollen supraclavicular node, a Virchow's node, strongly suggests malignancy. On the flip side, cervical nodes lean more toward TB or sarcoid. We check for tracheal deviation to see if a mass or fibrosis is pulling or pushing the airway, and of course we listen closely for localized wheezes or crackles. Now what's really interesting about these findings is how they map directly to the underlying pathology. We use the old reliable inspection, palpation, percussion, and auscultation method. For example, if you percuss the chest and get a dull sound, and then auscultate and hear bronchial breathing and increased vocal resonance, boom, you've just localized a consolidation, like pneumonia. But if it's stony dull and breath sounds are just totally absent, you're probably looking at a pleural effusion. Finding these specific clinical patterns lets us localize the mass or the hemorrhage way before we even order an X-ray.
And that naturally brings us to Step 3, the forensic tests. We always start non-invasively, right? Bedside pulse ox, some initial lab work like a full blood count and inflammatory markers. Most importantly, we order a sputum analysis. From there, we move to imaging. We start with a plain chest X-ray and then graduate to the gold standard, a high-resolution CT scan looking for cavitary lesions or masses. Finally, if we really need to see the bleeding firsthand or grab a tissue biopsy directly, we go in with a bronchoscopy.
Section 3. TB versus bronchogenic carcinoma.
Based on our patient's symptoms of coughing up blood and massive weight loss, our trusty algorithm has narrowed the field to two main suspects. It's time for a face-off. Let's walk through this differential matrix to contrast their clinical profiles. Take a look at the demographics first. TB usually shows up in patients from endemic areas or folks who are immunocompromised or homeless. Carcinoma, though, that typically strikes patients over 50 with a heavy smoking history. Symptom-wise, TB brings the fever, night sweats, and a chronic productive cough. Cancer is a bit different. It usually presents as a subtle change in a chronic cough paired with severe cachexia or body wasting. On exam, TB might give you cervical nodes, while cancer shows up with those supraclavicular nodes and digital clubbing. And finally, on imaging, TB classically forms a cavity in the upper lobe, while bronchogenic carcinoma usually appears as a hilar mass.
Now, to definitively lock in the diagnosis, we've got to rely on specific lab tests. For TB, the absolute gold standard is the acid-fast bacilli or AFB smear and culture, along with rapid GeneXpert testing of the sputum. But for bronchogenic carcinoma, we need cold, hard cellular proof of uncontrolled epithelial growth. That means getting tissue cytology or a direct biopsy, which we usually snag via bronchoscopy.
Section 4. Managing massive hemoptysis.
Let's shift gears for a second. Imagine you're waiting for those lab results, and suddenly the clinical picture completely changes. The tension in the room spikes. Your hypothetical patient starts coughing up a massive volume of blood. We're talking well over 100 milliliters in a single episode. They are crashing. We have to immediately pivot to our rapid-fire ABCDE emergency stabilization protocol. Step 1. Airway. Listen closely, because this literally saves lives. You absolutely must position the patient with the bleeding lung down. Gravity is your best friend here. It keeps the blood from spilling into the healthy, non-bleeding lungs so the patient can still exchange gas. Step 2. Breathing. Administer high-flow oxygen, targeting a saturation of 94 to 98%. Step 3. Circulation. Get 2 large bore IVs in STAT for aggressive fluid resuscitation, and get ready for a blood transfusion.
Now, what if the bleeding just won't stop? That's when we deploy our heavy medical and surgical arsenal. We can push tranexamic acid, or TXA, intravenously to help slow the bleeding down. We might do a rigid bronchoscopy, which, by the way, gives us way better airway control than a flexible scope, allowing us to suction out massive clots and literally wash the bleed with ice-cold saline or topical adrenaline. But the absolute first-line interventional procedure for massive hemoptysis, that's bronchial artery embolization, or BAE. That's where a specialist goes in through femoral access and actually blocks off the hypertrophied bleeding vessel.
Section 5. Reaching the conclusion.
Thankfully, in our scenario, the rapid stabilization worked. The bleeding is controlled with BAE, the airway is totally secure, and we actually have the luxury of time to review those lab reports we sent off earlier. We've brought the case back together. But here's the thing. Patient care doesn't end just because the bleeding stopped. Whether our final diagnosis was an infectious cavity or a bleeding tumor, there's a golden rule in respiratory care you've got to memorize. So, the crucial point is this. You must ensure a 6-week follow-up chest x-ray for all pneumonia or hemoptysis patients over the age of 40. Why? To make sure the pathology actually resolved and to completely rule out any hidden underlying malignancy that might have been hiding behind all that blood or infection on the initial scans.
And this brilliantly illustrates the whole point of today's clinical explainer. When you're standing there facing a terrifying high-stakes presentation like hemoptysis and cachexia, you just cannot let panic dictate your actions. Trusting your clinical algorithm, methodically moving from history to targeted exam to precise investigations, that is what keeps you grounded. That is what saves your patient's life.
All right, I'll leave you with this final, somewhat provocative thought. You've learned how to stabilize the patient and you know how to narrow the differential, but always keep in mind that razor-thin margin of error we have in respiratory emergencies. Think about it. What if the next 150 milliliters of blood fills that anatomical dead space before your lab results even come back? It's a really stark reminder that in medicine, knowing your textbook physiology is every bit as critical as knowing the disease itself. Keep studying, keep trusting those algorithms, and I'll see you on the next explainer.